Now that we're all here, I want to summarize what our job is, and as usual, I will be taping the entire procedure. Our faces are not shown for our protection. We committee members have to be more careful about our safety after the murder of my Idaho counterpart by a relative of a patient who was rejected for treatment. The camera behind me is running as of now. I am a federal administrative law judge and Alabama's Health Choices Commissioner. I'm here with a former nurse's aide and a health administrator from the Federal Coordinating Council for Comparative Effectiveness Research, or FCCCER, to evaluate the proper treatment for 16 patients who have appealed their cases to our state's coordinating committee and have been refused treatment by those bodies or need treatment approval as a formality. To repeat, these patients have already been reviewed at state level and sent on to us for their final and permanent solution or disposition. There's no appeal once we make our decisions. Ma'am, would you please describe your experience in the healthcare field?
I was a nurse's aide for the past 5 years, and I've recently retired. This is my first review meeting. Will we be recording the entire meeting?
Yes, ma'am. All procedures are recorded, and the tape's kept for 5 years after each meeting. Sir, would you please state your background and qualifications?
Thank you, Judge, for including me in this committee. I have an MBA from Emory University and work as an analyst of cost versus benefit studies in the healthcare delivery systems. I've been with the FCCCER since its beginning in 2010.
For the record now, this is the Cost Benefit Committee meeting on 23rd of May 2013 in the Federal Office Building in Montgomery, Alabama. Our job is not to establish whether an expensive procedure or treatment modality is needed or even life-saving, but rather to establish whether or not it makes sense economically to spend that much money and get the most for our taxpayer dollars. We look at the cost and then the benefit to that patient. Fortunately for us who work in this agency, our medical care or that of our families is not subject to cost-benefit analysis if we personally require expensive treatment. We are fully covered as part of our government benefits by the same separate health insurance as our United States representatives, senators, White House staff members, the President and his family, and key civilian employees of FCCCER and their families. We are exempt from this type of control that the general public must submit to. We can have virtually anything we want in medical or surgical care without need for any justification, except as a formality. I have a chart here which was on the agenda. A 54-year-old male who requested an MRI 10 months ago because of suspected mesothelioma in the chest cavity. He was not rejected, but when we finally got around to doing the MRI and the radiology office phoned his home to get him to come in, he had died the week before. His doctor sent an autopsy report saying that it was indeed mesothelioma. He is too long dead for the procedure now, so we can discard his chart. Our first patient is a 75-year-old male. He is a heavy smoker, using 2 packs a day for the last 50 years. He also drinks moderately and does not exercise. He wants a 3-vessel surgical procedure to help with his anginal chest pain. We predict that he has no more than 3 to 4 more years of life, even with the bypass. Comments?
This sounds like an expensive procedure with little likelihood of cost-effective benefits for the expenses this surgery would entail. I would suggest he be treated medically and use palliative medicines to relieve his angina pains and forgo the expensive surgical remedies for this man.
Oh, I agree. He's no longer a productive citizen and he doesn't seem able to take care of himself. Why waste money on him for a futile end-of-life surgery?
My feelings exactly. I vote no.
I vote no.
No.
It's unanimous. I will let his healthcare team know of our decision.
What happens if the patient is willing to pay for the entire procedure?
We have run into this before, and our policy, similar to Canada's, is to deny someone who is part of the richer population the right to jump the line and take away or delay treatment for the less fortunate. Why should they get preference just because they are part of the wealthy class? They can be prosecuted if they attempt to buy their way into unapproved medical or surgical care. They can still go to other countries for treatment, but they don't tie up valuable health care resources in the United States. There are clinics along the Mexican border, in the Bahamas, and on 2 hospital ships that take wealthy patients on treatment cruises, as they call them. Our next patient is 32 years old, a non-smoker, and an extremely moderate use of alcohol. He earns enough to be paying substantial taxes and has 2 children still in school. He also has extensive coronary artery disease and angina pectoris. He has, on the average, from 20 to 30 more years of life if we treat him. I consider him a still productive, tax-paying citizen and recommend he be approved for coronary bypass surgery. Please let me know your opinion. I will be voting yes.
I vote yes for this man.
I also vote yes.
Our third patient is a 3-month-old male child with Down syndrome and hydrocephalus. It's requested that we approve a neurosurgical procedure to shunt fluid from one part of the brain and thus relieve the pressure inside of the head. The child also has a number of congenital heart abnormalities. The lifespan is estimated to be no more than 2 more years, even with heroic treatment. I feel that this would cost the taxpayers a lot in hospital and follow-up care. I recommend no.
This is a pathetic case, and I agree that the expense can't be justified. Even though there is a definite need for neurosurgical intervention, I vote no.
I also vote no. This would be ultimately not cost-effective treatment. Why spend any healthcare funds on a hopeless and non-productive patient? It just doesn't make sense. It's similar to our refusal to pay for any heroic and usually futile management of high-risk, low birth weight, premature infants. Some of these babies need up to 4 months of expensive treatment, and if they manage to live by being treated conservatively, then they can be sent home, and the hospital isn't stuck with a usually non-collectible bill. Why should we spend more than $500,000 for just one baby?
All of us agree on that.